David Martin. I'm the Executive Director at the American Board of Orthopedic Surgery. I'm joined tonight by Mike Bednar, who is the Associate Executive Director at the American Board of Orthopedic Surgery, David Elstein, who is our Manager of Communications, Denise Frazier, who is our Manager of Certification and Credentialing, and Kristen Kaba, who is our Manager of Examinations and Assessments. And what we're here to discuss tonight is the Part 2 oral examination application. We'll go over the nuts and bolts of what you need to know before applying for the 2027 ABOS Part 2 oral examination. I like to start with the ABOS mission statement, and our mission statement has not changed in the approximately 91 years that we've been in existence, but it's depicted here. We exist to ensure safe, ethical, and effective practice of orthopedic surgery. We do that by maintaining the highest standards for education, practice, and conduct through our examination, certification, and maintenance of certification programs, and we do what we do for the benefit of the public. In addition, I want to focus on one of our guiding principles before we go on. The ABOS believes that there's no place for bias or discrimination within the field of orthopedic surgery or within our organization, and we have certainly invested in that guiding principle to try and make sure that we uphold that. I'd also like to show you a picture of our board of directors. They are supported by our full-time staff in Chapel Hill. Our board of directors is made up of 20 practicing orthopedic surgeons, just like you, and one public member. And I show this to let you know that it's a dedicated group of people who serve on a voluntary basis, give up 4 to 6 weeks away from practice, away from family each year, again on a voluntary basis, to set our strategy, to set our programs in our direction. And they're listed here with their years of initial board certification, their years of recertification, and then finally there are several who are subspecialty certified in either orthopedic sports medicine or surgery of the hand. By way of overview, the webinar tonight, we'll talk about board certification requirements. What are the requirements to sit for the Part 2 oral examination? We'll talk about the application nuts and bolts, just what you need to fill out the application. We'll talk about the case list and patient-reported outcomes program. Finally, at the end, we can answer your questions. If you will raise your hand in Zoom once we're finished, we'll unmute you. You can then go ahead, ask your question, and then if you'll lower your hand after that, then we'll move through the questions in the order that they're asked. So the Part 2 oral examination, preparation for it consists of 4 parts depicted here. You need to meet the requirements, submit a case list, complete the Part 2 application, and finally submit an application fee. All of the required documents and fees are submitted through your ABOS dashboard, www.abos.org, and log in with your username and password there. So let's talk about meeting those requirements. The first requirement is that you must take the ABOS Part 2 examination within 5 years of passing the ABOS Part 1 examination. That is the time when an individual is ABOS board eligible, from the time that they pass the Part 1 examination, extending for 5 years, not counting time in fellowship. Okay, so let's start with full and unrestricted license to practice medicine in the United States or Canada. You need to have started practice and been granted hospital admitting and surgical privileges on or before November 1 of 2025. That's these deadlines that we'll talk about are not negotiable, and we'll really we want you to know that we stick to those. The next thing is also important. You need to be continuously and actively engaged in the practice of operative orthopedic surgery, other than as a resident or fellow, in one location for at least 17 full calendar months from that November 1 date through March 31 of 2027. In addition, you have to have hospital and practice affiliations must remain the same during that 17-month time period, and you must have full hospital admitting and surgical privileges throughout that time period. There has to be at least one hospital that you have privileges throughout that time period from November 1 through March 31 of 2027. So, submitting a case list. You will submit all surgical cases from January 1 of 2026 through June 30th of 2026 in which you served as the primary surgeon. We do not want you to enter cases where you serve as a co-surgeon or an assistant surgeon. If you dictate the op note as the primary surgeon, those are the cases that you need to include. There is a list of procedures not to include, and that's found at our website, www.abos.org. There's a list of procedures not to include on the case list. You'll be putting in a medical record number. That is generally the hospital or surgery center medical record number. If the facility doesn't assign a medical record number until the surgery occurs, you can use a chart number initially from your practice and then change that to the medical record once that number is available. So, during that 6 months, if you're away from active surgical practice for 10 or more consecutive business days during the case collection period for any reason, we back up the starting point from January 1 to December 1 of the previous year to be sure that we get an accurate sampling of your practice. If you're not engaged in active surgical practice for more than 30 consecutive days during the case collection period, please contact the ABOS office and we'll try and make arrangements so that we get an appropriate 6-month case list. Active surgical practice is defined as being actively engaged in the operative practice of orthopedic surgery. That's seeing patients and or operating. We understand that there may be 10 consecutive days where you don't perform a surgical procedure. If you're seeing patients, that's not time away from practice. If you are not seeing patients for 10 consecutive days, you need to let the ABOS know. There have been some questions about that 6-month time frame, January 1 to June 30th. I will tell you that if you change your practice appreciably during that time frame and the ABOS Credentials Committee gets information about that, you are likely to be deferred to the following year. We're not anxious for you to change your practice. We're anxious to get an accurate sampling of 6 months of your surgical cases. So the cases are submitted through your ABOS dashboard. There's detailed instructions in what you can see on your dashboard is entitled Information Packet, Preparing Your Case List. There are also instructional videos there. I really encourage you to look at that information packet and watch the instructional videos on the ABOS website. Those are the ones that actually count. The next question we sometimes get is, why do we need a case list? What really is the case list for? And I can tell you that there are a couple reasons. Number one, it gives the board a good idea of assessing a candidate's practice. By looking at 6 months of surgical cases, we can really get a good idea of an individual's practice. It's an opportunity for you to do a self-evaluation of your performance in practice. As you go through that 6 months and then follow those patients for another 6 to 8 months after that, very carefully, that will be a learning experience for sure. Finally, we do give you at the end of all of that, after the results of the exam are reported, you do get a case list feedback report. Part of that is listed here. It compares the cases that you did during that time period to people in your same subspecialty, to all of the people who took the Part 2 examination, looks at the top 3 CPT codes and gives you a lot of comparative information that can be useful. Finally, the case list is the basis for cases that we choose for you to present at the Part 2 oral examination. So we will choose 12 cases from your surgical case list for you to present. As far as patient-reported outcomes, we collect patient-reported outcomes for all of the surgeries that you perform during the collection period. And the way we do that is for you to enter the case information as you schedule the case. So if you're starting to schedule cases now in January, you can start entering your cases. The case list is open now. The application's open as well. That information may be entered by your surgery scheduler. It has to have the patient's email address in it. And we have some templates for communicating to your patients to let them know that they will be receiving patient-reported outcomes emails at time 0 before their surgery, at 6 months, and then at 12 months post-operative. We send those PRO questionnaires by email at those 3 time frames. The questions will vary depending on patient response. So it's anywhere from 3 to 8 questions. We do have both English and Spanish. If you'd like to know what the survey looks like, we look at pain interference and also physical function. You can register yourself as a patient and it will send you the survey. You can see what that looks like. Just remember to delete yourself so you don't end up on your own case list. And that outcome information from the patient-reported outcomes is utilized by the ABOS Credentials Committee. And then again, at the same time, we provide the case list report. You also get a very nice report that you can go through patient by patient and patient groupings to look at their T-scores. There's some information on the website about how patient-reported outcomes work if you're not familiar with that. But you'll be able to look at your patient's physical function and pain interference at those 3 time frames for the patients that are able to respond to the questionnaire. That initial screen looks like this. You can see that you input the hospital, surgery center, the patient ID, initials, age, patient sex. Finally, pick the surgical date. That description, max 100 characters. We want a very brief description of the surgery. So you can click down near the bottom if the patient opts out and says they don't want to do that. If you opt out of every single one, that will be a problem and a red flag. Once you get to the actual scribe list, after you've entered the pros information, then after the case, this will self-populate up here from that first screen, and then you put in the date of surgery, the diagnosis code, ICD 9 or 10, the treatment code, and then at the end of the case list entry, you'll put in the date of last follow-up. So the application is available now. The application and case list are due on August 15, 2026 at 4 p.m. Again, pay attention to our deadlines. We hold to the deadlines. August 15, 2026 at 4 p.m. We'll talk about the late deadline in a couple minutes. The application requests basically information that's routinely found on applications like this. It'll ask for your practice location, so you want to have partner names and emails available. The hospitals and surgery centers where you have admitting and surgical privileges, we need a current letter indicating your original appointment date and type of appointment. Not your original appointment letter, but a current letter that says your original appointment date and what your type of appointment is. And then we'll need the names and emails of the individuals listed in the lower left there: Chief of Staff, Chief of Surgery, Chief of Orthopedics, Chief of Emergency Medicine, Chief of Radiology, Anesthesiology, the Head of Orthopedic Nursing, and the OR Nursing Supervisor for each of those institutions. You'll need to have your state medical license, license or licenses with the dates and the license numbers. And finally, there'll be a drop-down menu of ABOS diplomates, and you'll be able to select 5 who are familiar with your practice to help us with peer review. So we utilize all those names and email addresses to submit, to solicit peer review surveys. Our peer review process is comprehensive. It's incredibly important for us to be able to evaluate individuals with a 360 peer review prior to sitting for the examination. What happens is that those individuals are sent an email with an electronically accessed survey that asks them questions about your patient care, surgical skills, professionalism, and communication. The sources for that peer review, again, are those individuals you list on your application. We also take a zip code list of individuals in your practice area and send peer review surveys to them as well. So, what are the costs? Again, if you meet that deadline, 4 p.m., August 15th, 2026, okay, it's, 9 months from now. It's $975 to submit the application, the case list, and that fee. After 4 p.m., you'll pay the late fee. The late fee is $500. You then have an additional 2 weeks to August 31st at 4 p.m. Again, if you don't submit by 4 p.m. on August 31st, you're not able to take the examination the next year. Those are hard and fast deadlines. Once you're accepted to sit for the examination and you get your selected cases and start the uploads of documents, you'll pay the examination fee. That'll be in June of 2027. So, in April of 2027, once you submit that application in August, we start that process. Collect peer review, look at the case list, evaluate each person. We then select 12 cases from that list. In April of 2027, you'll be approved to sit for the examination and you'll get a list of 12 selected cases. You will then begin to upload documents and images for each of those cases. Again, there'll be an information packet available on your dashboard. Follow the instructions carefully on what you should and should not upload. They're in the information packet, and you'll hear me say this a lot, but you should do these things yourselves. If you hand this off to somebody, it most likely will not be done correctly. So you really want to look at the upload of the documents and images and do that yourself. The day of the examination, just to cover that briefly, there'll be email instructions as to when and where to meet. Pay attention to those instructions. The times are on there as to when you need to be where. Generally, we'll be at the Palmer House. Everything you've submitted for the 12 selected cases will be available on the examination computer. The booth looks much like what is depicted on the right here. So you have all your documents and images on the computer in front of you. You select the images to show on the big screen. The two examiners across from you have all that information on their computer as well, along with the scoring sheet. You'll sit through 4 sessions of 30 minutes each. There's a 5-minute break between each session. And in each session, there'll be 2 examiners. They'll evaluate you on 3 of your cases. That's about 8 to 10 minutes per case, so it goes pretty fast. My advice would be to arrive early and dress in professional attire. Our examiners give up a week away from their practice to spend that time in July in Chicago to perform the examinations. So you want to keep in mind the job that they have to do as well. The scoring of the examination is critically important to pay attention to the scoring of the examination. The scoring rubric is on our website. You can download it. It's a PDF file. I would encourage you to do that. I would encourage you to pay attention to the categories: data gathering, diagnosis, interpretive skills, treatment plan, surgical indication, technical skill, complications, outcomes, ethics, applied knowledge. You should be able to click those off in your mind as you're presenting your case. Each examiner will give you a score in each of those 9 facets, excuse me, for each case. They use a scoring rubric that you'll see across the top. Again, the scoring rubric is critically important. As you upload, as you prepare to present your cases, you should consider each one of these facets. The examiners see each of those, the words on that document on their score sheet, and they are adjusted for severity leniency. So when they give you a 3, that's adjusted up or down based on the severity or leniency of the examiner. You can go ahead and move forward, David. Great. Now let's go to the next slide. So in preparing, I encourage you to look at the videos on our website to review the scoring rubric. You need, again, upload yourself, upload early because you can practice with the documents on that platform. It's critical that you look at the documents on the platform. As you upload them, you need to look at how they look, pay attention to how you name the documents, because that's all in the instructions, and that will help you at the time of the exam. But you want to get that done early and practice. If you wait until the last week to upload, you won't get done. And so it's a couple month period, but you really need to start early. Next slide. We do have accommodations. So if you need accommodations for whatever reason, we have an alternate date for life events. We have other accommodations. The information and request forms are available on our website. If you have any questions at all about that, please don't hesitate to call us, and we can work through that. So just by way of hints, be honest. You're speaking to orthopedic surgeons just like yourself. Everyone has complications. If you look at the scoring rubric, not only are complications graded as to how they're dealt with, but how they're avoided as well. So if you have a case that doesn't have a complication, you want to just include a little bit in your presentation of what complications you were worried about and how you avoided them. That takes you one sentence, but that is very helpful to the examiners. I would practice with colleagues, and they have to have the scoring rubric in their hand. And I would choose people who aren't your biggest fans. And you really need to go through each case and go through the scoring rubric with someone who can look at that with you. There's a lot of information. You got one packet now. There'll be another one next spring. Pay attention to those. If you have any questions, don't hesitate to call. You need an informed consent for each of the 12 selected cases. Obviously, it's not a time to argue with the examiners. It's a somewhat of an artificial situation because you will not receive any feedback. So they will ask a question, listen to your answer, and move on. They are only scoring cases. They're not trying to educate you or make you better. They're scoring those 12 cases so that we can make the appropriate plus minus board certified, not board certified decision. Next slide. So the process: enter the PRO's information at the time the surgery is scheduled. You can work on the other case list sections after the surgery is performed. Submit the case list application, pay the application fee through your ABOS dashboard. Again, the deadline's August 15th with a late deadline of August 31st. Those are both at 4 p.m. They're non-negotiable. There is a late fee of $500. We then obtain peer review the case list, and then we move on in April of 27. You will receive an email as to whether you're approved to sit for the examination or not. Let's go to the next slide. And you'll receive the list of 12 selected cases. Between April and June, you'll upload the required documentation. And again, there's videos on our website. I'd encourage you to watch those. Finally, once you've finalized those uploads, there's a deadline and a late deadline for those as well. Those are hard deadlines as well. You can imagine for this examination, we have over 200,000 images and over 200,000 documents uploaded. It sometimes slows down a little bit right at the deadline. We've done everything we can to avoid that, but you just don't want to wait till right at the deadline. And then you'll pay the examination fee. Next slide. And finally, you'll take the examination in July of 2027. As we schedule things, you'll find out your date and time in early June by email. And then finally, we report the results in early September. Please keep the ABOS updated throughout your career with your contact information. Your email address is critical as you move from residency to practice. If your email changes, you need to let us know because we communicate by email. We spend a lot of time to make sure that the emails we send you are specifically for you. We don't send blanket emails to every orthopedic surgeon in the country about various deadlines. We specifically pull lists to send emails that are specific to the people who receive them. Next slide. Finally, the people who can help you, our certification specialists pictured here. Denise is with us tonight. They are assigned to our candidates and diplomates based on the first letter of your last name. Their emails are there. The phone number is there. Please don't hesitate to call with questions. We're here to help. Next slide. Again, keep your email up to date and don't be like Tyrannosaurus Rex. Don't miss the deadlines. Every year there are people who do, and we try and be firm with the deadlines. So make sure you keep your email up to date and pay attention to those deadlines. Next slide. Finally, as you progress through your career, we have a residency to retirement roadmap on our website. This is the front page of that infographic, and you can click on residency, initial board examination, maintenance of certification, and it'll show you all the details of what you need to do to maintain your board certification throughout your career. Next slide. Finally, we're active on social media. There's a lot of information on our website. There's a website for your patients to let them know what you're going through to become board certified at mycertifiedorthopedicsurgeon.org. Look for us on these platforms. Next slide. We have a podcast hosted by David Elstein, who's with us tonight. This is where it's located, although you can find it wherever you listen to podcasts. I would look at some of those podcasts. There are podcasts with people who have uploaded, people who have been successful in the exam, people who have talked about various parts of the exam, and then also orthopedic leaders is a very, very good spot to get information. Next slide. Finally, that's the information that we have to share. If you raise your hand in Zoom, we will call on you. This webinar will be posted by tomorrow afternoon, and you'll be able to either listen to it again or watch it again, and we'll go to the questions.
So our first question is Dr. Lawrence.
Hey, can you hear me?
Yes.
So I started my job on October 1st, and there was a delay with my credentialing due to some administrative issues, but I was granted temporary privileges in the middle of October and began operating before November 1st, but didn't start whatever my permanent privileges. Would that technically be acceptable as rolling into my admission privileges being approved in time for that November 1st deadline?
Denise?
Yes, we accept those temporary privileges. When you upload that letter from your hospital, it needs to state on there that you had temporary privileges on or before November 1st.
Okay, great. Sounds good. Thank you.
You're welcome.
Dr. Belena? I don't got it right.
Yeah, hi. I wanted to see what are some of the reasons why an application would be turned away for sitting for boards?
That would be after submission of the case list.
Yes.
Yeah, so that once the case list is submitted, we obtain peer review. So peer review is carefully evaluated by our credentials committee. The case list, we evaluate the case list as well to look for various outliers. And then all that information put together is reviewed by the credentials committee. So it could be the application, it could be the peer review, it could be the case list, be a combination of those. It could be one of those three.
And if you're rejected or that application is rejected, do you get feedback about what it was that may have caused the rejection?
Yeah, in general terms, yes.
Thank you.
Dr. Kolivar?
Yeah, hi, can you guys hear me?
Yes.
So for those 12 cases that are selected, what imaging are we required to submit? Specifically for sports medicine cases, like arthroscopic images, do you guys need a digital copy? Are hard copies okay? What do people typically submit for scope cases?
So, yes, you need to have pictures for arthroscopic cases, and they're uploaded. They can be uploaded as JPEG files, and they can either be uploaded one panel at a time, or you can upload a picture with multiple panels, depending on the case and what you have available.
And then screen recordings of MRIs and stuff like that as well, or how does that work?
Then no, MR. Well, other images are there. We don't have movies per se, so they're fixed images, but you upload either one panel or several panels at a time. That's outlined in the instructions. So the requirements for what's needed to be uploaded.
Okay, thank you.
Dr. Tubey?
Yes. So I have two questions. The people that we select for peer review, do they have to be the people that we are currently working with, or could be people from our fellowship or residency from previous institutions?
So two things. The people that you're currently practicing with will hopefully be represented on the application as you list your partners and the individuals in your practice or around the hospitals or surgery centers where you work. Then you choose 5 diplomats from a drop-down list, and those are individuals who are familiar with your practice. So that can be individuals from fellowship or residency, or individuals outside your practice in the same geographic area.
In the same, okay, so they can't be like, let's say, from Canada if part of my training was in Canada.
So again, you could choose a fellowship director. That person will probably be already on the application. But you could choose someone who worked with you in fellowship.
Okay. Okay. And then the second question is there a minimum number of cases that need to be logged in 6 month period?
Yes, sorry, I meant to mention that. You need to have 35 surgical cases
Okay. Thank you.
in the 6-month period.
Dr. Schneider?
Hi, yeah, thank you. For the case list submission process, Dr. Martin, there was that section that said description of surgery, max 100 words, and you were kind of describing what that box was for, then you kind of cut out. Could you explain a little more what you want in that section?
Sure. We want a brief description of the case. So what we don't want is a paragraph. I guess it's more important what we don't want. What we would like is a brief description of the case. Right knee arthroscopy with medial meniscectomy. Intramedullary nailing of midshaft tibia fracture. Hemiarthroplasty for hip fracture. That just a brief description of the case. Right total hip arthroplasty, left total knee arthroplasty, left unicompartmental arthroplasty. Hopefully that answers the question.
Yeah, it does. Thank you.
Dr. Wichern?
I just had one more quick question about the peer references. In general, if you're in a subspecialty, for example, I'm in spine, is it better to have your ABOS like diplomat peer references be all people that are in spine? Like I'm in a group where I have 2 spine partners, but then I also have a number of other orthopedic surgeon partners. Should I be listing those people too, even though they're not in my immediate subspecialty, but they're in my practice? What is there a preference on like subspecialty, I guess, for those?
So you need a list of people in your practice up to how many, Denise?
12.
12. Up to 12 people in your practice. If you have more than 12 people in your practice, the 12 people in your practice who are closest to your practice, whether that be either in subspecialty or geographically close. So the people in your practice you would list. And then the 5 diplomates can be in your subspecialty, but do not have to be.
Awesome. Thank you.
Dr. Articus?
Yeah, so you mentioned that we have to keep the same privileges as the hospitals during those 17 months. If I keep my privileges at my main hospital, but add an additional hospital during that 6-month period, does that cause any problems or is that okay?
That's okay. To add in hospital is okay. You need to have at least one hospital that you have privileges from November 1 to March 31.
Okay, great. Thank you.
Dr. Rodwan?
Thank you for your time. I'm in a situation where I have one partner with me in hand surgery, and sometimes my partner assists me in some of the cases when we don't have residents or fellows. Can I include those cases as long as I am the primary surgeon?
If you're the primary surgeon, so if you pre-op, consented the patient for surgery, did the surgery with your partner, dictated the op note as primary surgeon, and then did the follow-up, then you would enter that case, yes. Does that answer the question? Hopefully.
Yes, thank you very much.
Okay, great.
Dr. Clegg?
Hi, I have questions regarding the PROs. So one is, what if the patient is non-English or non-Spanish speaking? Is there a place to um, list that when you're submitting them? And then also for trauma patients who you're, taking more urgently, if you're unable to get their emails and all that sort of stuff, how do you handle the PROs for those patients?
Yeah, those are good questions. And sorry, that probably was a time when one of the times I was having technical difficulty. So I apologize for those. So there is a checkbox there for patient opts out. So if the patient doesn't want to do it, you check that box and move on. With regards to trauma patients or unscheduled cases, you can put those in the perioperative period, and actually the survey will ask the patient to look at their preoperative status, and that's been validated as pretty good representation of where they were preoperatively. So in a trauma patient, once you get the email, you can enter that. That will go to the patient and will ask them what their condition was preoperatively. So hopefully that takes care of that issue.
Dr. Powell?
My question was, if you have privileges at 2 hospitals and like I have block time at 2 different hospitals, I will have held credentials at both hospitals for the required time from prior to November through whatever. Do you submit all of your cases that you did at both of those hospitals, or do you sort of pick a primary location that's going to be your ABOS kind of constant hospital and only submit all of your cases from that hospital?
No. It will be every surgical case that you do, no matter where you do it, whether it's at the hospital, the surgery center. There are procedures on the list that are acceptable that are done in office. So every surgical procedure throughout that 6 months.
Thank you.
No problem.
Dr. Schmidt?
Hey there. I have another situational question, just relevant to myself. So as far as the November 1 start date, so I joined a private practice. I started my practice with multiple hospital affiliations well before November 1st. We have a PSA agreement with a rural hospital, and I'm taking over the hand portion of that care. I was granted privileges before November 1st for that. but my first day of clinic at that hospital was November 3rd. Would that cause an issue as far as being eligible for boards if I'm operating on patients at that location?
No, no. As long as there's one hospital where you have privileges from November 1 through March 31st, you can add a hospital,
Okay,
and that's
perfect.
not a
Thank
problem.
you for clarifying.
Dr. Darlow? Matthew Darlow, Low?
Hi, sorry. Of the 35 case minimums, does a certain percentage of them have to be of the fellowship that you trained in? For example, I did spine. So does like more than 50% have to be spine related, or it doesn't matter as long as you hit the minimum?
Right. The surgical cases again, orthopedic cases, but just 35 surgical cases. So whatever
Great,
cases you
thank you.
do, obviously some people, in their first couple of years of practice are not as focused, and so that's okay.
Doctors sorry.
It's me.
Yes,
Okay.
you.
Okay. I have a question for the application. I will take the part one exam next year, July 14. The deadline for part two is now August 15. That time I still do not know my result from part one. Can I still apply or wait for 1 more year?
So let me understand this. You're taking part one in 2026.
July 14.
Uh-huh. So need that he would not be able to apply, correct?
You're taking it through the academic pathway, correct?
Yes.
Okay, I'm
Yes,
sorry.
you
Okay.
will be able to apply in 26 for the 27 exam. Just know that if you do not pass the part one examination, you will forfeit that application fee and that case list and application, and you'll have to recollect all that information after you've passed part one.
I see. It's better to wait for 1 more year for the next cycle, right?
Yes, sir.
Okay. Thank you.
You're welcome.
Yeah.
Robles? Rabbles? Emilio? Emilio Robles? Rabbles? Doctor, is it Fontan?
Hi there. For the PROs, is that only for the 12 cases that are selected, but we still have to get consent from the patients from every single surgical case, correct? So by the time you guys reach out, if they provide their email, is that my understanding? Then they can fill out the PROs?
So you do the patient reported outcomes are on every case, every patient that goes into your case list.
Okay. Thank you.
So yes, yeah, from the start. So, and just to go back, there was a question about cases within a subspecialty or outside of a subspecialty. So we would like to see all of the cases, surgical cases in that 6-month period, and then we tailor the oral examination such that examiners will be familiar with the cases that are selected.
And just for everyone, hands up. We have a lot of people trying to get through as many as possible, but just warning. Well, so let's give another chance to Emilio Robles. Rables. Dr. Tabrizi.
Hello. Hi, my question
Yes.
was about one of the slides that said for every case we have to upload a consent form. Is that the surgical consent form, or what was that referring to?
Yes, that's correct. That's one of the documents that is on the required list. That's one that sometimes gets missed, so we just like to highlight that.
Dr. Wetzig?
Yes, I think it's been sort of answered now, but is there a percentage of fellowship-specific cases that trigger an all subspecialty examiner board? And does that have any implication on your, the certificate that you end up getting, designating that?
No. No and no. We tailor the examiners to generally to the overall case list and the 12 selected cases. So if you are a sports medicine fellowship trained surgeon and 60% of the cases on your case list are trauma and your 12 selected cases are mostly trauma, we will look for individuals who are comfortable examining in trauma and sports medicine or vice versa. So, but that's to ensure the best examination possible. It doesn't have anything to do with the certificate.
Thank you.
I think it's Dr. Is it Esposito?
Hi, can you guys hear me?
Yeah.
Yes.
Thank you for the presentation. So I have a couple questions. One, so I'm currently in fellowship, and I just wondering about the mailing list. Is this something that I need to change in my ABOS profile so I still get this invitation next year because I don't sit until 2028? That's my first question.
As long as you keep your email up to date, you should receive that.
And there's
Okay.
space for two of them. So if you want to have your second one be your Gmail, whatever personal one, that's always beneficial.
Yeah, I was just wondering if I needed to change something in my profile, letting you guys know that currently in fellowship, or is this just everybody that could sit for the test at this point that receives this email? That's why my question was. And the second thing is that you mentioned that the collecting list is open already. Could I start using that for some of my cases during fellowship to start practicing? Will not affect the cases that are actually going to be selected later in the future, right?
So no, you wouldn't want to submit cases from fellowship. I mean, you shouldn't submit cases this year.
Okay.
In any event.
Thank you.
Right, and you received the email. It's generally people who are 2 years out from who will be 2 years out from passing part one. We have no way of knowing who's in a fellowship and who's not.
Thank you so much.
Mhm.
Dr. Zalzala?
Yeah, hey, can you hear me?
Yes.
Yeah, so if a job change is likely within the 17 months, what's your recommendation on how to proceed?
So if your job changes during that time period, then you would not be able to sit for the examination. And so you just want to keep in mind that November 1 to March 31st date. So if you're saying you started November 1, last month, and you're not sure you're going to make it until March 31 of 2026, I'm sorry, 2027, and you're going to be going to a new job, you want to get there before November 1. Otherwise, it costs you another year. that you just have to be somewhat strategic with the timing.
Okay, thank you.
Versus if you can stay there till March 31 of 2027 and then change that works.
In terms of application, then do I just proceed and, the normal steps and upload the cases and stuff like that? Or do you think if that's going to happen, just wait until the next cycle?
If you can stay there till March 31 of 2027, then you can start uploading. If you're not going to be there until March 31, then I would
If you're not going to be there till March 31st, that 17-month requirement, then you shouldn't apply.
Sounds good. Okay, thank you.
You're welcome.
Dr. Cornegie?
Yes, Meg Cornegie here. I just wondered how patient-reported outcomes are collected on pediatric patients.
So pediatric patients, we do not have that capability right now. So those would be opt out.
Okay, so I'm all pediatric, so I should just, all my cases that I log, I don't need to collect like a parent email or anything?
Well, so if you feel like the parent could fill that out, that's the one exception there. If you fill in the parent name, that works as well.
Okay, thank you.
Dr. Matthews?
Yeah, this is C. Appreciate y'all doing this. Couple questions. Any circumstances or tips on what you should do if like the C-arm images or your scope pictures did not save for a certain case? Like hypothetically, let's say that's already happened to me. What would you recommend in those circumstances?
So you still need to submit those cases. If it's if you have post-op images, that's sometimes pre-op and post-op images are sometimes enough. If there are other like cases on your case list, and a case like that was chosen, if you contact us immediately, we can sometimes reselect the cases. Not always.
Thanks.
So, yeah.
Dr. Jabara?
Hi, thank you. My question is regarding consent forms. I looked at the consent form at my hospital, and it's kind of a blanket form with very little specific orthopedic surgery risks. I am documenting those in my preoperative notes and consultation notes. Do I need to figure out a way to have an amended consent form at the hospital, or is my consultation note with an extensive risk discussion sufficient?
So I don't think you have to alter the consent form. You'll be presenting your cases to orthopedic surgeons who work in hospitals who understand. So you would present that and say, this is the consent form from the hospital. This is how I obtain informed consent. And if that's a practice, if you're comfortable with how you obtain informed consent, you just need to convince the examiners to be comfortable with that as well. So but you don't have to change the consent form. We understand that there are hospitals that require certain forms and don't allow those to be altered.
Thank you. That answers the question. I do have a second question regarding the form listed in the Part 2 examination resources labeled authorization for use and disclosure of protected health information. Is that a form that all of the patients need to fill out during the case collection period, or only those who are selected for the 12 cases?
So that's not you. You need to sign a business associate agreement with the board. But you're referring to a form for patients. Is that
I
correct?
believe it says printed name of patient or authorized
Yeah.
representative. So yes, it's a patient.
So that's a sample that we came up with. At the time that you're uploading, you will need to redact certain pieces of PHI. If you have permission from the patient, then you don't have to redact. And the examiners are instructed, if it's not redacted, that means you have permission from the patient. We leave that in your hands. That is a sample form. You can use your own form, whatever you and your institution are comfortable with. And if the patient, either signs that or says, I'm okay with you putting my PHI in there, then you do not have to redact. So some people do that on all the patients along the way so that when the 12 are chosen, they have that. The other option would be to wait until the 12 are chosen and then contact the patients and have them sign a form of that nature. Does that make sense?
That makes a lot of sense. Thank you so much.
No problem.
Dr. Kennard? Go ahead, Dr. Kennard.
Oh, hi. Yes, thank you. My question is regarding those of us in the military. If deployed during the collection period, how does that affect our collection? And then also, how would that affect if deployed during the 17-month period when we're supposed to be at one hospital?
So generally we would like for you not to be deployed during that time period, and we have the military has been reasonably cooperative with that. If you are deployed, we would need to juggle the 6 months. And then what was the other part of that question? Oh, afterwards, if you're deployed, then you just need to get the follow-up from the people who are doing the follow-up when you're deployed.
Okay, thank you, sir.
No problem.
Dr. Badford?
Hi, Badway. Good evening.
Good
So
evening.
I had two questions. One is I'm part of a large health system, and my primary location is where I work, but we get a lot of courtesy privileges with the other hospitals across the state. Um, I believe I'll be submitting all my cases from my primary location, and I really don't have any block time at the other locations. Do I still need to get some paperwork or some letters from those hospitals? I mean, I'm not sure if I need to cover that aspect.
Denise?
You need to list every facility, regardless if they're under one administration umbrella in your application. If you've only done cases at a couple of those places, you only list your case list. You don't have to get any information for the case list, but you do have to list it into the application. You can get one letter and upload that letter for each individual facility as long as it mentions the name of that facility in the letter.
So that would mean, do I have to get a letter from, say, the OR supervisor from each of the facility that I did not work there?
No, you would get a letter verifying your hospital privileges at the facility for your application. If you didn't do any cases there, you don't need anything for your case list from that facility if you didn't perform any cases.
Correct. Not even any letters from the manager that I did not do any cases. Just to clarify.
Correct. We changed that this year.
Wonderful. And my second question was the hospital where I work, I'm the only spine surgeon. My other partners are non-spine orthopedic surgeons. Some of them are DO. But my spine partners work at different locations. So when I do my peer peer letters, peer references, how should I kind of balance that? Do I provide the information of my my practice partners or my other spine practice partners who work across the system at different locations?
As long as they're familiar with your particular practice, you can list them as your diplomates, your 5 diplomates. You can list the DOs as your partners into the application, up to 12.
But
Uh,
your
but
partners, you list your 12 closest partners. So if that includes the other spine surgeons, that's fine. But the people practicing around you are probably going to be the best options for peer review. And then
Okay,
you can, if there are spine surgeons at other locations that are familiar, then you want to go ahead and include those in those 12 for your practice partners.
got it. And does it have to be 12, or does it have to be like if you have less than 12 partners, or 12 is
Well,
the
yeah, if you have less than 12 partners, list all of them. If you have, more than 12, we just want the 12 who are most familiar with your practice.
got it. Thank you very much.
Dr. Chube?
Yes. So if patients do not fill out prompts, let's say they consented, the email is provided, but you send them an email and they don't answer, do those cases get eliminated?
So what, I guess I'm not sure I understand. These are patients who went to the OR and you operated on,
Yes.
but they
And
don't respond to the
yeah,
patient-reported outcomes.
exactly.
Is that right?
Yes, correct. Is this my connection?
Denise, do you want to jump in?
I'm sorry, what was the question?
So let's say the patient consented to receiving the questionnaire for prompts, but then the email from your group is sent to them, but they don't fill out the form. Do those cases get eliminated? What happens?
No, that doesn't get eliminated because they didn't complete the pro survey.
Okay.
Let's go, Dr. Mesa.
Yes, thank you. I appreciate your time. While I understand that the goal of the ABOS is to understand and get a glimpse of our practice, is there a, a template or something as far as documentation is concerned to understand, preferences or just sort of hints as to the way documentation is preferred as far as um, consultation notes, progress notes, etc., or is it just completely left to the applicant?
So once you're uploading, there will be certain documents that are requested. And those are the ones that you might consider pre-op notes, the clinic note where the decision for surgery was made, the operative note, post-op follow-up notes, various consults. So what that, again, we don't want you to change the way you practice medicine. So if you're comfortable with it and you think it meets the standard of care, then that's fine. I mean, that's sort of what we're looking for. We don't have templates for notes or op notes or those types of things. These are, orthopedic surgeons who are evaluating other orthopedic surgeons.
Thank you.
Dr. Rao?
Hi, thank you for doing this. Is there any documentation that you need to sit down with the OR managers at our hospitals to go over the case lists that we submit? Do they double check it with all the cases that we've done or anything of that sort?
Yeah, well, yes, someone will need to verify the case list that it contains all of the surgical cases that were done during that time frame at each institution.
So that will be for every hospital that we would be operating at.
Correct.
The individual OR manager would have to do that.
We've expanded the list slightly. It was medical records, understanding that many hospitals don't have medical records, individuals. We have expanded the list of people who could verify that.
And do we need to include physical therapy notes within the documentation that we submit?
So for physical therapy notes is a no, but that'll be in the information packet as there's a list of things that you really need to include, and then there's a list of things that you should not include.
Okay, thank you.
Mm-hmm.
Osadabe?
Thank you. Thank you for putting this on, Dr. Martin. I just had a quick question. You touched on this about a bit ago about getting additional privileges at other hospitals, even though you already had privileges before November 1st. Does that also apply to getting additional privileges at a surgery center? Is that okay? Or is it strictly as hospitals that it's okay?
No, you can add privileges at a surgery center.
Perfect. Thank you. That's it for me.
Okay.
Dr. Myers?
Yes, two quick questions. One personal of I'm a spine surgeon. I do my own injections and ablations. And I'm pretty sure those are not included CPT codes. Is the op notes and documentation related to those procedures leading up to like a real like a fusion or decompression surgery, are those expected to be included?
So that's a judgment call. What we would tell you to do is include information that you would present if you were presenting the case to another orthopedic surgeon. So it would just depend on the situation. If I had an injection 4 years ago and then I come in today with a slightly different problem and we end up operating on it, probably not. However, if I come in, I have a problem, it's treated conservatively, treat an injection, doesn't get better, and goes to the OR, probably if you were going to present that case, or if I was going to present that case to you, I would tell you about those things and have that documentation there.
Mm-hmm. Now, would I be judged on an ablation or injection procedure that I did like right now versus within the actual collection period with submitting those op notes?
So if you operate on somebody during the collection period, that's the case that somebody would focus on.
Mm-hmm.
But when you're presenting the case, right, data gathering, diagnosis, interpretive skills, treatment plan. So the time leading up to doing the operation includes all of those things, right? What data did you gather? What tests did you do? We did an injection that didn't get better, so therefore we looked here or there. We did this study, we did that study. Now I'm past data gathering, diagnosis, interpretive skills. These are the diagnoses I looked at. This is one I decided on. Now we're in the treatment plan. So all of that contributes to that particular operative decision. So that sounds like something I would include.
Okay, thank you. One more question, quick one. Is there any advice on maintaining acceptable documentation when working with residents?
So that's a good question. I mean, I think it needs to be something that you're comfortable with. So if you're, you know, at times you co-sign the notes, at times you don't. If at your institution you don't co-sign the notes, then, you just need to make sure the notes are what you would be comfortable with. If the notes are not very good, you need to teach the resident and improve the notes. And certainly, many of our examiners work with residents and understand that. The process is what would be important. You'll see these are resident notes. I see the patients with residents. They dictate the notes. I review all the notes. I review some of the notes. Depends on the resident. whatever you feel comfortable with is what you would present.
Okay, thank you.
Dr. White.
Hi, thank you all. I just want to go back to the question about the patient-reported outcomes. It sounds like they are being asked in only English and Spanish, and how is that dealt with a large patient population who speaks a different language? Is that from the board's perspective?
Different than English or Spanish?
Correct.
Then you would need to click the opt-out button because those are the languages we have right now.
Okay, thank you.
Dr. Prathakar. Sorry if I mispronounced
Yes.
that.
Oh, it's okay. Pooja Prabhakar. Regarding the PROs for patients who are like they have dementia or for some reason they can't fill out it on their own, would the person who filled out the consent form for them, like their spouse or their children, would they be able to fill that out on their behalf?
Yes, that would be fine. Yes, their email would fit. Yes.
Okay, thank you.
Dr. Moga.
Good evening. Thanks for taking the time. I have a question regarding the peer review process for those surgeons who may be practicing in Canada who have lots of orthopedic surgeons around, but none of them are diplomates.
So those orthopedic surgeons would be listed on your application. If they did not, if there were additional, the 5 additional orthopedic surgeons who were not on the drop-down menu, you need to contact your certification specialist and we could work through that.
Okay, thank you.
Dr. Charles. Charles.
Yes. Thanks for doing this for us. Just a quick question for the PROs. Are there any that we personally collect from patients, like SANE scores or anything, or is that all through the board, through the email provided pre-op?
So the ABOS patient-reported outcomes program includes physical function and pain interference. So that's what we collect on the patients. If your practice collects other information, that's fine. We don't want you to stop doing that. So if you're, collecting information in various areas, that's fine. And, some of that may be included. If you run through the scoring rubric, there are parts of that that refer to, how's the patient followed up and how do you decide if they're doing well or not well? And that's where some of those things may come in.
Okay.
I mean, you don't have to do those, but if that's how you follow patients, then you want to include that. And we
All
don't
right.
want to change, again, we don't want to change your practice. If that's something your practice is doing, and it helps you and it's a good thing, then I would continue to do it.
All right. Thank you.
Dr. Shaw.
Yes, hi. Thanks for thanks for doing this. My question is for those of us who anticipate being out for a little bit more than 10 business days um, during the collection period, who can we contact in order to enable access to the portal to be able to start adding cases in the December period?
That would be your certification specialist, correct, Denise?
Okay.
That's correct. Morgan Graham.
Okay, great. Thank you very much.
Dr. Glenn.
Hi, thank you. My question is about the consent form from like surgical consents. Uh, my hospital recently started doing electronic consent, so any inpatient trauma, that the residents technically consent before I see them and the resident sign, is electronically uploaded before I talk to the patient and sign. Is that going to be an issue? Like, should I print it out and sign it and have them re-upload it, or is that appropriate?
So if that's how you do it in your institution and you're comfortable with that and you can explain that and it seems reasonable. I don't think that's a problem. It's obviously it's the process that's most important, and various hospitals do things various ways. So I think our examiners understand that. Uh, so I would say to do what you're comfortable with. But I think if that's your hospital practice and you say, this is how I'm comfortable that this patient received informed consent, I think that's fine.
Okay, thank you so much.
Dr. DeBeese?
Yeah, hi, can you hear me?
Yes.
Yes.
Thanks for putting this on. My question is if you have a PA, do you guys have any recommendations on the typical follow-up and documentation similar to the resident question? Do you recommend we do all the follow-up or have our PAs help us out with that?
Again, I would recommend you do it as you practice, as long as you're comfortable with it and it makes sense, right? If I'm presenting a patient to you and I say, yeah, I did the operation and the PA handles the follow-up, I don't usually see him again. That's probably uncomfortable. If I say my PA sees the patient at their first post-op visit, I'm in the same clinic and it's a PA I've worked with and I trust, and they know when to call me, and then I see him at the second post-op visit, or I see the first one and they see the second one, deliver safe, ethical, effective care. And so, yeah, I mean, lots of people use APP. So
We don't want you to change your practice. If your PAC the follow-up, then that's what you need to note in your notes and your documentation for the cases.
Okay, thank you so much.
You're welcome.
So those are all the questions. Dr. Bednar, do you want to close it out? Any final thoughts?
I'll be glad to do that. Thank you all for your attention tonight. There have been some great questions. Hopefully a lot of the details have been answered as we've gone through. As was mentioned, this will all be uploaded onto the to the website tomorrow, so you can review things again if other points are unclear. So thank you for your attention. We hope everyone has a good night.